Hemophilia, there are many clotting factor disorders. Look, clotting factors, there are many clotting factors, and then their disorders can occur because of genetic issues. Liver makes the majority of the clotting factors and destroys them as well. So if there is a liver disease, the clotting factor issues would occur. Potassium is very, very important for clotting factors to work correctly because it helps with the modification of the clotting factors. So any potassium deficiency would cause the clotting factors not to work correctly. So then calcium is needed for the clotting factors as well. So there are many reasons that a clotting factor or factors may not work correctly. We are today going to talk about two most common clotting factor issues. One is called von Willebrand factor disease, and the other one is called hemophilia A or factor VIII deficiency. These are the two that I want to touch upon today. So let's do it. It's a very, very interesting one. And let me say it up front again. The problem with these patients is that nothing to do with COVID-19 in terms of severity. But once the patient becomes severely ill or seriously ill, then look what we are talking about. We are talking about clotting factors. What is the function of the clotting factor? Help with the clotting. So when the hypercoagulability state of COVID-19 sets in, that is the serious and critical situation. If that happens, then we need the clotting factors to do the thrombosis or to do the clotting inside the blood vascular system. And now, if the clotting factors are not present, then the bleedings will occur. That is a problem. Otherwise, hemophilias themselves do not do directly anything with the COVID-19. The other one possibility is that when we give medication for hemophilia, this is where the fresh frozen plasma belong, which I had written back there in thalassemia. So when we are giving fresh frozen plasma, or when we are giving, for example, immunosuppressant, this drug here, which is you can say it's a synthetic factor VIII. It's not synthetic factor VIII, but it acts as a factor VIII. And we do not know that when the COVID-19 is in our body and it is trying to cause damage and our body is now trying to respond by creating thrombi, will immunosuppressant work correctly at that time? So we'll see that. So let's first understand the mechanism of hemophilias. So von Willebrand disease. And this name, von Willebrand, was by two scientists or doctors who actually discovered this disease. So their names are used. One was von and the other one was Willebrand. So let's see. I have been making this diagram again and again. So let's look at this diagram again. This is a blood vessel. In the blood vessel, there are many, many cells present, but we are more interested in platelets. We are interested in where the von Willebrand factor is present. So I have watched some YouTube videos where they say that the von Willebrand is present under the endothelium. So that's not entirely correct. And maybe for the simplicity's sake, that is fine to say. Von Willebrand factor is present under the endothelium of blood vessels. So that is this area. These blue blobs are von Willebrand factors. So they're present under the endothelium. For any reason, if there is damage to the endothelium, so let's cause some damage, which COVID-19 can cause, right? So let's say the blood vessel is damaged here because of COVID-19 and here because of COVID-19. So there is an area of defect here. Then what happens is once there is a defect, then this subendothelial von Willebrand factor becomes exposed to the blood products, and that is what would help with the platelet aggregation. I'll go to that in a second. Let's look at where von Willebrand lives first. So one area is area A under this endothelium. Second area is inside the endothelial cells. These egg-like cells are endothelial cells. These are the ones that are lining the surfaces of the blood vessels, endothelial cells. Inside the endothelial cell, there are vacuoles or bags, which are called Weber-Palade bodies. And these also have von Willebrand in them. So endothelial cells themselves have von Willebrand factor sitting in them. When the endothelial cell become activated because of some stress to the blood vessel wall, they can release the von Willebrand factor. Or when the endothelial cell breaks down, just like an egg that breaks down and you get the yolk and the white, similarly, when endothelial cell breaks down because of damage, the von Willebrand factor can be released from it. And then von Willebrand factor, this blue ship here, this guy, is also freely floating inside the blood vessels as well. And why is it freely floating there? It binds the factor 8. And remember, factor 8 disease is called hemophilia A. So we are talking about that today. So these green blobs are factor 8. If we do not bind factor 8, so I'll tell you a little story today. My wife takes Luffy out every day nowadays before our talk so that he doesn't make too much noise. So today when he went out, he was not on a leash, so he almost ran out of the backyard. So luckily she was able to bring him back in. That is the same situation here. These factor 8s are like Luffys. If you don't bind them to von Willebrand factor, they would just disappear from the blood and we'll have a deficiency of them. So we say that von Willebrand factor inside the blood vessel binds and stabilizes factor 8. And factor 8 is very important for clotting. Correct. Similar to alveoli sac system. Correct, Guy. So now think about it. First thing that should be in your mind, to keep in mind is number one, where the von Willebrand is present. So subendothelial, that is one. Number two, B is within the endothelial cells as Weibel-Plade bodies. And then C in the blood stream binding to the factor 8. This is a normal behavior. Now, let's look at what happens. In von Willebrand factor disease, the factor 8, there are actually 3 types of diseases. We said type 1, 2, and 3. In these diseases, type 1 has minor deficiency in production of von Willebrand factor. Most of the time, because of a minor deficiency, these patients do not bleed that much. Remember, we're talking about clotting factors which help with clotting. So if there is no clotting or less clotting, then patients would bleed. What would happen, for example, their gums would bleed when they eat food, or when they are doing some strenuous exercise at joints, they will be bleeding inside the joints or bleeding inside the tissues. So these are the bleeding disorders. In type 1, the von Willebrand is present in sufficient quantities that normally in normal activities there is no bleeding disorder. But still these patients, when they do some highly strenuous exercise or when they are undergoing a surgery, they may need help because their von Willebrand factor may not be enough. That is one. Second, type 2 is usually that von Willebrand factor is present, it is lesser than 1, or it is present in the right quantity, but the shape of the quality of the von Willebrand factor is not correct. And when the quality is not correct, it does not function correctly. And in this, there are again 4 types. I don't want to go in them, but type 2A, B, C, D. In this type 2B is very interesting because in type 2B, the von Willebrand factor shape is so incorrect that somehow platelets do not like it. And whenever it is present, it would bind with the platelets and cause aggregation, which causes thrombocytopenia or reduction in the levels of platelet, which in itself is a problem with the blood disorders or bleeding disorders. So keep that in your mind as well, because sometimes when we give medicine for von Willebrand disease, what the medicine does is that it releases the von Willebrand factor from the storage sites. And now if you give, for example, Desmopressin is used as that medicine. So if you give Desmopressin to a patient of type 2B, von Willebrand factor disease, their D-shaped von Willebrand factor will be released in the blood, which in turn would cause thrombocytopenia, and another issue. So it is not given in those patients. Anyways, back here, and the type 3 of von Willebrand disease means total absence of von Willebrand factor. Of course, these patients would need, the total absence patients, they would need fresh frozen plasma or cryoprecipitated plasma with the factor. Now, what is the function of the von Willebrand? Let's just quickly look at that. What happens is once the blood vessel is damaged, like it was damaged here, then the platelets need to come in and make a plug here. And I had done that discussion a couple of days ago in hypercoagulability. So platelets needs to aggregate here and pack this damaged area and then suture it with, and then suture the packing. The platelets need the von Willebrand factor to bind. Von Willebrand factor binds with a protein which is called glyoprotein GP1, glyoprotein 1. So von Willebrand connects with that. So this glyoprotein or a protein or a receptor on the platelet is going to connect with von Willebrand. If von Willebrand is not present, then platelet cannot aggregate at the site of the damage, and that is the blood bleeding disorder. Because there is no aggregation possible, and so then what would happen is that the blood would start bleeding from here. Correct? Because we are not closing this area, and that is the bleeding. And when that bleeding occurs inside the joints, that causes deformation of the joint. When it occurs inside the tissues, it causes issues with the tissue, and then there is bleeding, so that causes anemia, and so there are lots of problems. So the very first thing for the platelet aggregation is for the platelet to bind with the von Willebrand factor. So that is an important thing. We know that once, from the hypercoagulability talks we did a few days ago, we know that once a platelet are bound here, then more platelets will be bound, then fibrinogen will be converted into fibrin, and the sutures will come in, and those sutures would have plasminogen in them, which in future would cut those suture. This is 4 or 5 days ago we did this talk. So we have done all that. Today we are just once again iterating the role of von Willebrand. Now, before we talk about the medication for this and the issues for COVID-19, let's just quickly look at hemophilia A as well. Hemophilia A is the deficiency of factor 8. Factor 8, remember, this is the factor that sits on von Willebrand and is stabilized by it. Otherwise, like Luffy, it would run away. So factor 8 works with factor 9 to help convert factor 10 to active form. And I know that we discussed this, that there is factor 5 needed as well. There is prothrombin or thrombin needed as well. There is calcium needed too, potassium needed too. So I'm leaving that all out. Just important, factor 8 and factor 9 are needed to activate factor 10, this one. Once the factor, and we are talking about the intrinsic clotting pathway. Once the factor 10 is activated, it converts prothrombin to thrombin, which then converts fibrinogen to fibrin, which are the suture material here, correct? This is how clotting occurs. Now, if the factor 8 is missing, then the factor 10 is not activated, and then the clotting will not occur. So that is another bleeding disorder. For both of these disorders, what are the solutions and what is the relation to COVID-19? Solutions are that we give, for example, imacizumab in case of hemophilia A, and imacizumab can act as factor 8, and that is the intermediate between the factor 9 and 10 here in this area. So imacizumab, we have no idea how would it interact with COVID-19's or SARS-CoV-2's hypercoagulability state. So that is an unknown, and there is no study yet. So that is a risk. But should the people stop taking it? No, because it is acting as a factor 8 and it is needed. So don't stop taking it, but the outcome is still not known. My prediction is that because it is acting as factor 8, it should be okay. But please don't stop using it. The other drug that is used is Desmopressin. Desmopressin is the drug that we talked about it a few minutes ago as well. It helps release by an unknown mechanism. Desmopressin is actually an antidiuretic drug. It is given for diabetes insipidus. But here, in case of hemophilia and von Willebrand factor disease, desmopressin, when given, it releases these factors. We know that it releases the von Willebrand factor from its storages, but we do not know from where it helps release factor 8. But both of those factors are released, which is excellent. So that is another drug that is used, which helps with the factor 8. Again, if you're taking that drug, keep taking it. It does nothing with the COVID-19, meaning it's not bad. The thalassemias here, the hemophilias here. Important thing with the hemophilia, let me go to that before we come to fresh frozen plasma. Look, the problem with the hemophilias is this. We talked about it, that the virus can cause, in severe cases, hypercoagulability state. If a person already has a bleeding disorder and then virus causes damage inside the vascular system and consumes the remaining clotting factors by making thrombi, then the patient is going to bleed and bleed and bleed. That is a problem. So the problem is not the factor itself doing anything. The problem is lack of the factor and then consumption of the remaining available factor for coagulation by COVID-19 would cause bleeding or would increase the tendency to bleed. Now remember that hypercoagulability state only happens in some people, number one. Number two, it only happens in serious and critical cases. I mean, it can start, hypercoagulability state can occur earlier as well, but it's not that damaging. But the one that is really damaging or concerning is the severe and critical state. So it's not that hemophilia patients are at too much of a risk, but if the disease progresses in them, not because of hemophilia, but for other reasons, then hemophilia can be an additive issue when the hypercoagulability state occurs. And so now, after these two drugs, imacizumab, we do not know how would that work. Desmopressin, it works and it releases those factors, which is a good thing. So keep taking it. Antifibrinolytic and estrogens are also used. So antifibrinolytic and estrogen, they help suppress the resolution of a clot or dissolving a clot. So that's fine. If you're taking those, keep taking them. And then fresh frozen plasma or cryoprecipitate are taken. The only risk here is that the cryoprecipitate may not be checked or may not go through the virucidal or viral killing processes. So that plasma, the cryoprecipitate, may have COVID-19, and that is a risk. Now, stay here and I want to talk about, can plasma actually have COVID-19? So our discussion is done. Look, when the plasma is collected, when the blood is collected, there are some processes that already mean that there may not be COVID-19. Number one, we do not know if the COVID-19 actually, SARS-CoV actually lives in the blood. So that's one. But we know that it causes hypercoagulability. So of course it goes in the blood and then connects with the endothelium. But would it actually be in patient's blood, in a donor's blood? Number one, donors are healthy, one. But I keep giving you the balancing points. Netherlands did a discussion, sorry, not a discussion. They did a research on 10,000 bags of donated blood. And they found out, what was it? I think 4 or 5% had the antibodies for COVID. That means they were infected. Now, does their bag of blood itself has COVID in it? I don't think so. So one, the patient normally do not give blood. Normally healthy people give blood. So hopefully they don't have COVID-19. Secondly, the process of collecting blood goes through, there are procedures that are antiviral. So the viruses are usually not present in the plasma, and there are antiviral chemicals, plus there are nanofiltrates as well. So having a virus in the plasma is difficult. And then the cryoprecipitates are the only part where it is possible that the virus may be there. So that is only risky area. So with this, today's discussion, it went for 1 complete hour, but I wanted to make sure that we have taken care of these things. The only one disorder that I wanted to discuss and I did not is the G6PD deficiency. So maybe we will have that discussion later on. So how was it? We talked about 4 diseases. There was a lot of material in there. Sickle cell disease are highly risk patients at risk, so we need to take care of them. So guys, thank you very much for your presence. Thank you for your time. I always enjoy these discussions. Tomorrow is my off, and day after tomorrow will start. Tell me this. Would you like to discuss on daily basis, other than the medical concepts, some global state as well, that what are various countries doing, how is the spread going on, what are they doing to contain the spread, who is opening, who is not opening, and what is going on? Would you like that as well, or continue talking medicine? Yes, acoustic theory, you're correct. His name was, I had noted it down, Ria C. I will be reporting him today, so they'll block him. Yes, so there was a lot. So tell me, yes, please. Joe says, yes, please. So is that for the, so I'll then do 2 talks. One will be medical talk, and then at a different time, I'll do another talk about the situation, how we are trying to come out of the this lockdown and what are various countries doing. Okay, perfect. So we'll do the global deal. I like closet pickers. Yes, the global deal. Yes. So then there is Kevin who's saying, just the medicine, please. Okay, we can do that too. I actually think that we should talk more. SARS present in blood. SARS present in blood. Sir, I'm from Bangladesh. Welcome. Welcome. What methods are working? Yeah, we should talk about that, Tylee. What are the methods that are working? What are the exercises people are doing? What are the procedures they have put in place? What drugs they're using? So I think it is important to look at those things as well. All right, guys. Medical talk, Hafiz says. Both. Cliff says. Mushtaq says, grateful, sir. Thank you very much, everyone. Thank you for being here. And I'm going to hang up now. Talk to you later. Bye-bye. Stay safe. We'll meet on Monday. Bye-bye.